Hi, my name is Hannah Gilmore, and I will be doing my presentation on floating to other units. Nurse floating is a pretty common practice. It is used to help compensate for the fluctuating census in different units. In healthcare, there's no telling how busy one unit's going to be, so it's just a way to compensate and sort of follow the patient volume. The community I work in who's affected by floating are the nurses at Shawnee Mission here in Kansas City. Advent Health Shawnee Mission is a 504-bed hospital. We recently received magnet status. That also includes a couple freestanding ERs and surgery centers. The culture at Shawnee Mission is changing, I've noticed. They've done a lot of different things with nursing ratios, and um, the problem with floating is as the ratios have been increased and vacancies have not been filled, nurses are having a heavier load. Therefore, when a nurse is floated to a new unit, they're absorbing a heavier load as well. And then they're leaving a heavier load on their unit for their coworkers to absorb. Um, Floating is something that happens at just about every acute care setting. Um, some nurses will say it's a necessary evil. The problem is when it becomes routine. Um, Sometimes one unit might get slammed with many admissions while the other unit has many dismissals, and that's why the first unit might have to pull a nurse from the second unit. You get into issues when there are units routinely, you know, low staffed, and then so other units are having to regularly fill in the holes. A great example of this happened on my own unit just the other night. Um, One of my coworkers said she's probably going to be quitting soon because she has to float so much. Um, it's floating as an expectation at my hospital and at many hospitals. A lot of nurses are unaware of um, their options and the ANA guidelines as far as floating. Um, I've been told at other hospitals that if you refuse to float, that's patient abandonment and you can be fired. Um, but like I said, it's a very common reason for nurses to quit their jobs. And just one of my coworkers said, she's been floating so much and taking care of patients she's not as comfortable with and having heavy loads on this other unit that she's probably just going to find a new job. There's lots of issues with floating. It's consistently on different surveys listed as one of the top 5 things nurses dislike about their jobs. It can cause a lot of anxiety. If it's especially a different patient population, that's really stressful. You're in a new environment with different coworkers and different leadership, and maybe the units are ran a little bit differently. When I was a new grad, um, they had built this beautiful new cancer institute, but it was set up differently from all the other units. And we were so busy all the time, and we were always getting float help from other units. But the problem was our unit was so busy when we got float help, no one had ever been cross trained to our unit. So by the time we got float help, no one had enough time to help out the float nurse. And we had this new beautiful unit with different stock rooms, and these float nurses didn't even know how to get how and where to get basic supplies for their patients. The American Nurses Association states that they uphold that registered nurses, based on their professional and ethical responsibilities, have the professional right to accept, reject, or object in writing to any patient assignment that puts patients or themselves at serious risk for harm. Registered nurses have the professional obligation to raise concerns regarding any patient assignment that puts patients or themselves at risk for harm. Floating, like I said, it's happened at every hospital I've worked at. Nobody loves or even likes to float, but every hospital, even before I became a nurse, had different ways to try to manage it. At my current job, I work for the float pool. It's sort of a unique float pool. The point of a float pool is to fill in the gaps and help out where nurses are needed the most and to be able to adapt. So hopefully we can, take the burden from some of the staff nurses, and so that they don't have to, experience that sort of anxiety when they have to float. There are a few benefits of floating. It is a cost-effective solution to compensate for a fluctuating census. It does give you an exposure to a new patient population, and you may learn new nursing skills or assessments. I think probably most nurses would argue that that is not the best way to learn a new skill set, but it's possible. There are many risks to floating. Patient safety is number one. Patients never benefit from a nurse who feels incompetent. Many nurses say this is why they leave their jobs. And then just the unfamiliarity for nurses. Most hospitals who use floating regularly justify it from a financial standpoint. They obviously don't want to work extremely short-staffed, but they also don't want to pay for travel or agency nurses or pay for overtime. A lot of states and nursing organizations and even some hospitals will have some recommendations, but nobody has any, set hard guidelines regarding floating. When I was a new grad, I worked at Via Christi in Wichita. This is probably the hospital that had one of the bigger problems with floating. Unfortunately, a lot of the time you did not receive prior orientation to a unit. So sometimes you just show up to work and they'd say, hey, you're going to this unit. And you sort of just had to figure it out and hope for the best. And unfortunately, by the time you floated, that meant that that unit was so busy and understaffed that people weren't able to help out. There's also no designated like sister units or pods or whatever you want to call it. They tried to keep nurses from floating to different campuses in the same shift, but that didn't always happen either. I remember one shift, my friend Kristen had to float to 3 different campuses in one 12-hour shift. While I worked there, they had a float pool, but they actually dissolved it for budget reasons, which was unfortunate. After I moved to Kansas City, I heard they reinstated it. When I moved to Kansas City, I worked at St. Luke's. They had a giant float pool. They had multiple levels. There's ICU float, ER float, med-surg float, labor float, just women's and children's float, lots of different things. But they could float to the 4 different major hospitals in the metro that St. Luke's owned. I think once they started really beefing up the float pool, people were skeptical that it was that these float nurses weren't going to be put on standby a lot, but I'm pretty sure they got their hours just fine. And the only time I witnessed a regular staff float was like if in the ER there are ICU holds, they would like pull an ICU nurse to come down and help. My current job, I work for the float pool, and basically you just tell them what you're comfortable doing and they'll just plug you in where you're needed. It's sort of nice. They also, the main units have sister units. For example, in labor, our sister unit is postpartum. So when you get hired on labor, you have to orient to postpartum um, on a normal day. So that way you're not being fed to the wolves, the first time you're floated there. A lot of different recommendations for floating. Another an unlisted recommendation that was brought up when I worked in Wichita was to maybe, instead of floating the nurse to a new unit, if one unit was not as full, admitting patients to that other unit. Like maybe if ortho was full, but med surge was not, instead of overloading the ortho floor, they would move their new admits to the med surge. That way, at least the nurses would be familiar with the environment they were in. Float pools are great. Float pools have proven to decrease overtime and really, lighten that burden. But it may take years to build up a float pool. That's why it's recommended for units to establish sister units and cross training during orientation and guidelines. Here's my reference page, and thank you for your time.